So I welcome you all on this last part of the post-COVID-19. This is totally our experience of COVID cases presented to our wellness center from July last week till just a week ago. And we'd like to share our data. We again reiterate that we are not experts. Please follow the guidelines of the relevant state and also of the our ministry's guidelines in treating these patients. But before we do that, we had posted one image challenge on our website cghsclinics.com. It was a case number 123, 82-year-old male. This is a snapshot from his wellness center visit. 82 male without any comorbidity has a gradual swelling of right leg as seen in this picture, and it is painless. There is a pitting edema on the right side. And what is the cause? So we'll take a poll. What do you think it is? The link is being posted on the WhatsApp and the Telegram group. Doctors can vote on the possible response. 82 male who has come with a swelling of the right leg. And what is your clinical diagnosis based only on the picture? We'll give 20 seconds for the presentation to register response. What do you think? If the male of elderly male comes to your wellness center, has this unilateral leg edema from almost thigh to the ankle, and it's a gradual onset. What is the likely? So 82 male coming to wellness center with a right leg gradual onset pitting edema of right leg. We have asked the clinical diagnosis just based on your first impression of the picture. So most of the doctors feel that this is a chronic venous insufficiency and DVT and arterial. Some people say it's arterial thrombosis. We'll see what it is. So what investigation you will advise next? Again, you can register your response. You can vote on the same link. It takes little time, few seconds to load on your mobile or a computer. So we'll give you 20 seconds for that. What is the next investigation? There's nothing right or wrong in this. It just assesses your approach to the case. Many of these investigation may be sequenced, but what is the most important investigation? So most would agree that this is a venous Doppler of the right leg. Few say arterial Doppler, and remaining are saying it should be ultrasound of the abdomen. So this is I also went by the Doppler, and this is the Doppler. The Doppler report says no sign of deep vein thrombosis in both the lower limbs. But there is an interesting finding which I hid below this yellow mark, and this is a multiple enlarged retroperennial and pelvic lymph nodes seen. And these are seen to compress the right external iliac vein. And of course, we would go ahead with CT scan. And this is the CT scan. of this patient. So patient had multiple enlarged necrotic retroperitoneal and iliac lymph nodes. These are necrotic and very much enlarged. The other finding is prostatomegaly with a heterogeneous post-contrast enhancement. The bladder wall is distended, wall thickening, and more on the lateral wall. And they suggested PET CT. So the message from this case is that anytime you have such case, DVT is always the first, but not necessarily it comes as a DVT. Also think about external compression on the major veins in the pelvis or the IVC, sometimes if it is a bilateral edema. And this is a very uh, one of the uncommon presentation how CA prostate presents. I do not know the final diagnosis of this patient because his grandson was getting married. He has not returned back from this advice of CT guided biopsy and surgeon's consultation. But this is how CA prostate will present. So multiple generalized lymphadenopathy in abdomen pressing on the IV, external iliac vein. So we come to our key topic that is a post-COVID-19 morbidity. So we had around 327 screened and just yesterday the count is 159 RT-PCR confirmed. We had so far 6 dates and these are all walk-in patients. This is nothing to do with our claims patients data. And we gave this post-COVID-19 functional scale. It's a very simple scale. There are only 5 questions that are asked. And these are the questions that you can see on the right side of your screen, that what are your limitations in everyday life uh, with related to symptoms, pain, depression, anxiety, sleep, and whether there are any limitations or not. And there are gradings on that. So there are 5 grades and the patient is asked to select only one. So our patients post 1 month, this is just at 1 month, you will see that majority, half of them are back to normal. No limitation in my everyday life and no symptoms. These patients are mild to moderate category patients of COVID-19. Few said it is a negligible limitations in their life to do regarding symptoms and pain and depression. So if you combine these two, very mild affection at the end of 1 month, and very few patients actually suffer from limitations, and few of these were very severe cases who required prolonged hospitalization because of oxygen or complication. So the hype of post-COVID morbidity in reality, if you combine these two at 1 month, it's not much. And this is what our patient has told us. This is not from any Western studies at all. Now, we also looked at the dyspnea scale. So modified MRC dyspnea scale, which everybody knows. And we asked at the end of 1 month, and some are people who have come little later also. So do you suffer from breathlessness? So most of the patients said this is just grade 1, but you can see almost 40, over 40% said they don't suffer from any breathlessness. Only two, these few patients were on oxygen. So obviously very small percentage here, but majority not a great breathlessness. What then we had questions about concentration, memory loss, and most of the patients said that they are able to concentrate on their work. Only few had some problems, but majority going back to normal life. Cough is a very common symptom post-COVID. So how many of them had? Only around a quarter, a little more. but majority had no cough. So this is also again one of the important post-COVID morbidity. Joint pain was seen in some of the patients, and it has been described post-COVID. So how many of them had? So not many, actually only a one third of the patient had some joint pains, but majority had no joint pains. And this is again a mild, moderate, and some are severe patients reporting to us 1 month post-COVID. For comparison, I have taken this slide from one of our patients who was diagnosed as IgM positive chikungunya. He had increasing arthritis post 1 month of the diagnosis. So he just came last week and see his fingers. And this is not COVID. This is chikungunya, which we see regularly. And he was very much in pain. So if we compare the post-COVID arthritis and post-chikungunya arthritis, this is looking more horrible than post-COVID. So I think the hype around post-COVID morbidity, it is little too much. There is some amount of comorbidity, but if we compare with our regular viral fevers like dengue or chikungunya or other illnesses, I think it's not so much. So muscle pain, it is more to do with the use of steroids and other medications. But this was the most common complaint of most of these mild, moderate, and severe patients, that they suffered muscle pain. 92 patients responded to this questionnaire that they had these muscle pains. So we come to our actual cases which we encountered in this pandemic. So this was a first case, 74 male who came hypoxic, 85 saturation. He walked in the wellness center. We immediately referred him for hospitalization, and he was clinically very suspicious of COVID. It turned out to be positive. He had a prolonged 1 month of hospitalization. He was on NIV. He had bilateral pneumonia on X-ray, but he made home, and this was his post-discharge. This is 2 months actually, post-discharge, post-COVID, and this is what the picture is. And he's not able to walk on his own. He requires some support. So what is your clinical suspicion looking at his picture? Please vote on the link which is given. 74 more male with a very significant history of ischemic heart disease. He had 4 angioplasties in the past. His ejection fraction was around 40%, but he still survived and went home. And the only complaint, major complaint post 2 months discharge was he's not able to walk on his own, which he could do pre-COVID. So what is your suspicion? So we'll wait for another 10 seconds. So most of the doctors so far are giving B proximal myopathy as one of the option, but others are not selecting. Others are not selected. Osteoporosis, bilateral osteoarthritis, osteonecrosis of femoral head. Is not able to walk. So this is a slide from New Zealand Medicine Device Safety Authority, and they looked at the short-term steroid use side effects. So if you see that most of these are related to musculoskeletal, and very few had osteoporosis. Vascular necrosis was very common. Osteonecrosis was also common. Myalgias, very few patients. So actually, we should also think about avascular necrosis. And this patient is still not able to walk fully, although he's able to walk without any support. But in last visit, he was telling that he has a pain over some of one of his hip, and we actually wanted to do MRI, but he was very reluctant to go back to hospital because of the mental trauma that he had. So we suspect in such cases not only myopathy, proximal myopathy, but also a vascular necrosis of the femur and osteonecrosis. This you should not forget in these patients. So this is a very important comorbidity. So this is again another case. Case number two, she unfortunately died, 58, diabetic, and she was on ventilator for a very long time, couldn't make it. But this is the picture that I have taken from her CT scan. If you look at the CT picture, if you find such reticular interstitial marking, these are very specific, which are seen in non-survivors. So this is a pattern seen in non-survivors. But there is one more finding in this picture. Please have a good look at this HRCT scan and point out where is the abnormality. I'll give you the link for the voting, but point out there is one more important finding in this CT scan. Have a close look at this CT scan. Please vote. Identify life-threatening non-pulmonary finding in this CT. I'll again go back to the picture. You have to type the name of the abnormality. There are no more ready-made answers given in MCQ format. So you have to type the abnormality. I'm going back to the picture. Anything which you can see. So it's a little difficult one, but would be a great CT scan for respiratory medicine postgraduates. So you can see here there is a air around the heart, the pericardium, and there is also some air around the trachea. You can see here pericardium is lifted up, and this is a pneumopericardium. You can see this very well. Yeah, somebody said a cardiac shadow. So, okay. Now we come to this young gentleman, 48 year old. He had a prolonged hospitalization for COVID. He was on oxygen. And this was 1 month post COVID CT chest. And this was taken at the lower lobe level. And after 2 months, I repeated his CT, and this is how the CT has changed. See the disappearance of these fibrotic strands. No more seen at the same level. No more seen. He attended tele-rehabilitation of CGHS Pune that we conduct every Thursday between 7 to 8. He took only nintedanib only for 3 weeks, but he discontinued because of side effects. So he just had a 3 weeks course of this antifibrotic drug. After that, he did not have. He joined his office and he's off oxygen. So he's a very young post-COVID survivor, and I was very much surprised after seeing the recovery on the CT scan, and I was very worried about his oxygen support, because even after 1.5 to 2 months, his oxygen was not off. But he attended our tele-rehabilitation. He learned all the exercises, breathing techniques, and everything. And very happy to inform that this patient had joined back his office, and he was quite young. His wife was very worried. So we come to the most important investigation that we did in our patient. We did forced oscillation test. This is called as FOT of the 49 patients of post-COVID, mostly mild and moderate patients, and some few, very few, less than five severe patients at first follow-up to our wellness center. And after that first follow-up, again, they had one more forced oscillation test. Now, forced oscillation test measures the resistance in your breathing tubes and the elasticity, what is called as reactance. So this investigation is grouped into bars. The first two are the resistance in the small airways. So this is a resistance at 5 hertz. You can see after 1 month, there is a drastic drop in these patients. This is a resistance of breathing tubes at 12 hertz. You can see the drop. Now, most of these patients, more than 90% of these patients, have not taken any pirfenidone tablet or nintedanib antifibrotic drug. They were just treated as a standard protocol, say plus minus hydroxychloroquine or favipiravir. And very few patients had only few days of steroid, not even a great dose of steroid, but no antifibrotic medicines in majority of these patients. And see the drop in the resistance of the breathing tubes at 1 month. This is just 1 month drop. So if I would have uh, carried them little further, I might see a further drop. But because of the constraints of the time, this test showed a significant drop. Now, this is a one more parameter which is called as a X5, that is a reactance at 5 hertz, which tells you about elasticity. More negative it is, that means elasticity is more affected. And when it is less, the elasticity is coming back to normal. So at 1 month, we are able to see a improvement in elasticity and decrease in the resistance. This is the very advanced lung function test and not a regular spirometry that we have done, because regular spirometry cannot catch these parameters at all. It is meant to measure only the lung volumes and flow rates, which do not show much changes. So we did this advanced lung function test, and it showed within 1 month a great improvement. So this is the first time that impulse oscillometry has been done. Sorry, the first oscillation test has been done in the world. We are still keeping a track of the research articles even today. There are no studies on such a kind in post-COVID patient. This is being done by us for the first time. We'll be publishing this paper, but for the first time, I'm disclosing my data to our audience. So we come back to our cases. Now this is a case 3. The 51 male post-COVID-19 1 day post-discharge is just discharged 1 day ago with a standby oxygen at home. He was a young beneficiary who was diagnosed in our wellness center but required a hospitalization. And he complained of increase in breathlessness and drop in saturation to 90%. The daughter calls me. These are actual incidents I'm describing. This is what actually happened. The daughter of the patient called me that she is bringing the patient to the wellness center, and choose the correct is our response. Which is which is correct? Which you think is a correct? Please vote on the same link that is given to you. 51 young patient who discharged just 1 day ago. The daughter calls you up that there is a drop in saturation, and she wants to bring the patient to the wellness center because the discharge hospital does not have any bed at present, and this is what the real situation was that day. And they directed the case to me, and she just wanted to get the patient. She was in panic. So the responses, the most of the people feel that there is a possibility of pulmonary embolism. This could be post-COVID fibrosis flare-up. There's full possibility of secondary bacterial infection. Okay. So what happened in this patient will disclose. I did not ask this doctor to get the patient to the wellness center. I told her to go back to any hospital which can accommodate. There was a severe shortage. This happened in September. The patient is still not joined his office. He's still on oxygen. Yeah, there are few responses that this could be a pneumothorax. So there is an acute change in the saturation of this patient post a 1 day discharge. And this was, as everybody correctly suspected, this patient underwent immediate CT pulmonary angiography after admission, and this was his report. Saddle thrombus extending from right pulmonary artery to left pulmonary artery, and it was an extensive pulmonary embolism, which we don't know because that whether it was missed, because he was already on anticoagulant. He was given heparin, and even post discharge he was given apixaban. So even if this would have been detected, the management would not have changed. But the magnitude of the embolism you can see from the report, and this is what the daughter messaged me the moment she got the report, when she found a place in the same hospital in the casualty. The patient was in casualty, and they got the CT done there. And fortunately, this patient is has recovered now. He's requires a standby oxygen. He's quite young, just 53 serving beneficiary, but he's still doing well. So these responses are correct. This any acute change in saturation, pneumothorax is still a good thought. Pulmonary embolism, fibrosis would take a time, and we don't know whether such an entity exists. Bacterial infection will not so acutely, it will not develop just within a day. It may take weeks. So in our patient of 217, which we saw post COVID, only this patient had a pulmonary embolism documented, and no other patient had any thrombotic episode. So this is a very rare case. Probably the hype of thromboembolism in mild to moderate patient at least is, I think, little hyped scenario, I feel, and it's not seen in our patient so much. Only few percentage are probably seen, but this is seen in other cases of sepsis or ICU admissions also. So we don't know whether it is a COVID giving more thrombotic episodes, or it is because of the critical care illness giving thrombotic episodes. So, but the incidence is very less in our cohort. So when does a readmission after discharge happen? If it has to happen, usually it happens within the first 1 week. And it happens in around 8 to 10% of the discharge patients. And these are the risk factors. And all these risk factors are present in our patient. He was a hypertensive. One of the factors present in our patient is hypertension. He was hypertensive, age more than 65, and if the patient had a fever 48 hours prior to discharge. So, and these are the reasons for admission: sepsis and thromboembolic episodes. So this is taken from one of the study from Italy. They studied what are the reasons for readmissions. In case if we overshoot the time, please rejoin on the same link, please. Now, post-COVID case 4, this patient had come today also. 64 male, she is 1 month post-COVID, and she has come with a bilateral pedal edema and bit of abdominal distension. She does not have any comorbidities. She does not have a breathlessness. Her saturation is 98. Limited examination is normal of the heart. There is no organomegaly. Distension is there. And this is the X-ray which done on a OPD basis. So 64 female post-COVID, 1 month, coming with pedal edema and abdominal distension. So ready for responses? What do you think this lady can have? Elderly lady, 1 month post-COVID, bilateral pededema, and that was the X-ray. What do you think she has? So few doctors, they say it's a pericardial effusion. I'll go back to the X-ray again. Have a good look at the X-ray. You can magnify. Some of the doctors who are using mobile, they can magnify the image also regularly. The way we magnify any image. Cardiac failure is one. There is no right or wrong. You can just to see the approach of different doctors. Bilateral pneumonia, few doctors feel that's a bilateral pneumonia. So this patient had come with similar complaint again today, and she was again asked to get admitted. She had same complaints, edema, breathlessness. This time it was, and she desaturated today. So these are the findings on the X-ray. You can see upper lobe venous diversion. There is a definite cardiomegaly. There is a bilateral effusion. So this is definitely cardiac. So 2D echo was done and CT pulmonary angio was done because everybody thought this is a pulmonary embolism also. So 2D echo showed enlarged right atrium, right ventricle, severe pulmonary hypertension. There was no pericardial effusion, but I would think with this X-ray, pericardial effusion also one of the very good differential. Cardiac failure, yes, this is post-COVID. There are lots of media reports of cardiac failure possible. So this patient had a cor pulmonale without evidence of pulmonary embolism on CT pulmonary angio. So we don't know why this has happened. There is no evidence of pulmonary embolism. Her D dimer is normal, but she has presented with cor pulmonale. So we do not know whether this is COVID related or she was having before COVID. But this is a very interesting presentation in this patient. So cor pulmonale post-COVID without pulmonary embolism. And this is one of our iconic case. Now this is case 5. The previous was actually 4. This is a very iconic case, and from this case, you will get an example of how the general practitioners make a mess of the case. This is a case 5, 62 female, COVID under treatment, home isolation of a local GP. Now, COVID is diagnosed only based on the CT. She was not asked to do RT-PCR. The GP straight away went with CT scan, and there are enough patches which looks like COVID, ground glass, subpleural, bilateral, and she had fever, cough, and body ache. And the GP did not advise RT-PCR. He just labeled this case as RT-PCR, this as COVID, and treated her. And after 8 days, the patient CT was repeated by the same general practitioner. And after this CT picture, the patient came running to the wellness center. and the arrows are showing you something. This patient is not breathless when I examined her in the wellness center. She is 8 days post after this first scan. I did her a walk test. We usually do all the patients of COVID. We do 3-minute walk test in our wellness center and see for a drop in saturation. So she did not have any drop in the saturation. But this was the CT picture, and she did not have a RT-PCR report. So what do you think based on the clinical capsule? A highly suspicious COVID case, a CT scan is repeated, and the patient is not breathless, saturation is okay, uh, she's sitting comfortably, and what are your likely diagnosis? So most few doctors are saying cardiac failure due to myocarditis. When I examined her, she did not have breathlessness, saturation was 98%, no drop post walk, and no fever, no tachycardia. Bilateral pneumonic effusion, because a few doctors feel that this is pneumonia both sides, so effusion alongside the pneumonia. Actually, the question is which of the following is least likely. The question is which is least likely. I'm sorry, I should ask the other way around. Which is least likely? This is a very iconic case. This I wanted to present desperately to our doctors. So what happened actually in this patient? This patient, we did an RT-PCR, which was negative. Rapid antigen was negative. But this was done around 10th day because it was not done. And they went ahead with the local corporation hospital where antigen test was negative. And by that time, she was all right. She was about on the verge of completing her home isolation. But interesting history was given by the relatives, and the patient was every day the patient was called to the GP's clinic for intravenous saline infusion. For 8 days, this patient was going to the GP clinic, breaking her isolation for 1 liter IV fluids. This was the history given at the end of the examination, when I was also thinking about cardiac failure, something wrong, something very weird about COVID, or some pleuritis. And she gave history that every day the general practitioner is calling for intravenous saline with some injection. So we know all what has happened. So this is a case of fluid overload. So it is the most uh, um, relevant answer uh, in this case. But obviously, fluid overload is seen in otherwise also. I have seen many patients post COVID who came to our wellness center with fluid overload, not because of intravenous saline, but somehow they developed this fluid overload, and we had to diuresis them, tell them to restrict fluids. So this was seen in few of the patient. So I think fluid overload can be considered as one of the differential diagnosis. So we gave this patient torsemide just for 5 days, stopped her. We asked her not to go back to the GP for any intravenous saline. Her 2D echo was normal. Her ECG was normal. We called her back after she finished the isolation, and she was perfectly all right. We did her retrospectively antibody test after 15 days, and they were strongly positive. If Dr. Sumitra is there, can we have her on case number 6? So this is one more very interesting case. I have seen two cases of this. 62 male, case number 6, 62 male was admitted for COVID, and he was given steroids and low molecular weight heparin. After 1 month, he is coming to the wellness center with the skin lesions at heparin injection site. Is CBC is normal, no thrombocytopenia, CRP is normal. What is your clinical diagnosis? These are mildly tender lesions which you can see. I would like to call
Yes,
Sumitra. Yeah,
I'm here.
yeah,
Yes, I'm here.
yeah. You can guide us through the case. We'll take the responses.
Um, yeah, these are actually,
We'll wait for their
yeah,
response,
yeah. Yes, please.
and you can take them with your explanation what it is.
Yeah.
Please respond to the quiz. Yeah. Yes, Dr. Sumitra, we can run the discussion now. I think they have finished responding.
Yeah. Um,
I'll go back to the lesion.
86. Yeah. Okay. These are 1 month duration lesions, and the majority have answered as post-heparin necrosis. But this is not the clinical picture of cutaneous necrosis. These are eczematous reactions to subcutaneous injections of heparin, which is a very well-known side effect of injectable heparin. So these are typically eczematous plaques. You can see solid lesions with surrounding erythema and the skin peeling. And I don't know if there was any oozing. Right now, they all look dry.
No, anytime
Yeah.
you have seen
Okay.
almost 2 months, up to 2 months.
Then this is a typical delayed hypertensivity reaction to heparin, which is an immunological reaction, and it's a very well documented side effect. And the management includes discontinuing the heparin and giving other substitutes, and treating it like any other contact dermatitis with topical steroid. And if symptomatic, you can give some antihistamines. So
Uh,
it's
yeah.
not a very common reaction. At the same time, we should be aware of it.
If this would have been ulcerated, I have seen the other lady who had similar lesions all over her heparin injection site, and she
Uh,
was, but her wounds were open wound with a discharge, and even after 2 months, the ulcers
uh,
were not healed. So in
those are probably necrotic lesions,
okay,
but not these.
all right,
Okay.
all right. So
So
I
these
will.
haven't ulcerated even after a month.
Yeah, yeah. In this
Yeah.
case, they have not ulcerated. But the
Uh,
other case, the lady's case, unfortunately, I don't have the photographs. But her lesions
okay.
were similar, but the only difference was ulcerations, and they were not healed even after 2 months of discharge from the hospital,
Mm,
and but very
okay.
chronic. We don't see this very often, I suppose.
It's a generalized reaction, Dr. Sudha.
Yeah.
It's a generalized hypersensitivity reaction, but the localization is at the sites of infection.
Thank you, Dr. Sumitra, for guiding on this uncommon skin reaction to heparin. So we can discuss later on more in detail. So
Thank
this
you.
is what we got it from one of the Lancet article, that these are the type of heparin-induced skin lesions that Dr. Sumitra was talking. Delayed type of hypersensitivity reaction. Because the patient did not have thrombocytopenia and no necrosis, hemorrhagic bullosis, pustulosis, and calcinosis cutis. Just for yes. So this is last case, I suppose. So this is a COVID post-COVID case 7. Young male, comorbidity, no comorbidity, and he has come with this laboratory report. 15 days post-COVID. I have marked with yellow. These are the abnormalities. So MCV is normal actually. Bilirubin is quite high, 6.7 total. Direct is within sort of normal, but indirect is very high. LDH is very high, 748, but is a mild case at home and does not require any oxygen, or he's not on any medicines other than vitamin C and zinc. We checked his B12, which is 104, not very low, that normally we see. So what is your clinical diagnosis? So we have a young male post-COVID, not very post-COVID, just 15 days. B12 is on the lower side, 104, indirect hyperbilirubinemia, very high LDH, more than 700. What do you think it is? Please vote on your link. COVID-related hepatic injury, COVID-related immune-mediated hemolysis. Few say megaloblastic anemia. Very dilemma case, what it is. And so most say that this is a hemolysis because of the COVID. I also thought of the same, and I was very happy, enthusiastic. I got the rare case, rare presentation. But when B12 came low, that clouded my clinical diagnosis. So we repeated his report a month later. Now you can see the HB has corrected. The COVID antibody is positive. Sorry, and I forgot to paste the LFT report. The LFT report has become normal. The bilirubin is normal. No more indirect hyperbilirubinemia. I gave him B12, oral tablet B12. So I do not know whether this is a post-COVID hemolysis that I am dealing with, or it is regular megaloblastic. But normally, in my experience, a megaloblastic anemia hemolysis would occur in a very, very low B12 levels. And usually we see undetected or less than 80 is the B12 levels where we see this kind of hemolysis. Uh, at this level, I do not know about the experience of other doctors, whether hemolysis is seen. So this was a laboratory proven hemolytic anemia picture in a post-COVID patient with B12, low B12. But his MCV was normal, which I don't know. Why was that? It may be combined deficiency possible. So this, we are coming to end of this presentation, and we have to disclose the winner of the essay competition. Total, we got 8 uh, essays from all over India, as long as from Shillong, a few from Chennai, one from Bangalore, and all were notable. They had different experiences. We'll be pasting them on our website essay section later this week. But we'll, based on the opinion of 3 umpires, I'm thankful to them. Dr. Kaushik, she evaluated these essays. Dr. Kameshwar Rao and uh, Dr. Patwardhan. So these are our notable essays. The winner is Dr. PVS Fani Shastri from Hyderabad. And there were many such good essays. Dr. Shubhalakshmi was very, very close in terms of giving fight to Dr. Fani Shastri and even Dr. Hema. Uh, but all because they were placed in a different situation, we uh, shared, we looked at the way of writing, the vocabulary, and everything, and our umpires felt that Dr. PVS Fani Shastri is the likely winner of essay. So I congratulate Dr. PVS Fani Shastri for writing a very nice essay. All these essays, all those who have, even Dr. Musina has also contributed in this. All these essays will be uploaded on our website essay section, and you will be able to read all of these essays. So I thank you every participant in this competition, and uh, also thank you judges for spending time on evaluating these essays. And with this, I like to conclude my presentation. If there are any questions, we can take them. Subbalakshmi has raised hands. Okay, please go ahead. You can unmute yourself and talk. Yes, Dr. Subbalakshmi.
So, can you hear me now?
Yeah.
Regarding the analysis of post-COVID symptoms,
Mm-hmm.
many of our patients are elderly, diabetic, arthritic, etc. Now, in such a scenario, when they come back after a COVID, how do you decide that this particular symptom is post-COVID and not a pre-COVID symptom which is continuing as post-COVID?
So normally the questionnaire itself asks the same way, that what has changed after post COVID. So we specifically give this questionnaire that after COVID, did you have all these symptoms after COVID? So only the question specifies that. I
Okay.
agree that there could be overlap. We don't know whether they had these symptoms pre-COVID, and this is a valid question, that whether they, for example, weakness, they might have had weakness before also. So there is no way to differentiate unless the questionnaire specifically tells you to only report that particular abnormality which is felt post-COVID. And this is all subjective now, because this questionnaire is given to the patient and they are filling these forms from their home, from their mobile. Then these are digital forms. Sometimes you ask them, but when we ask them, we ask specifically, did you have this post-COVID or pre-COVID? So this is how we recorded their symptoms.
Okay. Thank you, sir.
Any questions? Any presentations? Because somehow the Zoom is allowing us to continue beyond 50 minutes. So if anybody wants to share, they can share. I'll stop share.
I just wanted to add one point
Yes.
about the apparent case.
Mm-hmm.
We can confirm it by a skin biopsy and a histopathology.
Yes.
That
Yeah.
would give
Yeah. Yeah.
the final answer. I forgot to mention it at that point.
Yeah, definitely. I was also thinking about the other lady who had similar lesions. I was thinking of doing a skin biopsy, but those days, even the COVID patients were not getting
Yeah.
beds in the hospital. It was very, very difficult to, get a skin biopsy done. Most of the private clinics were also closed. So we had no choice but to continue conservative management.
For an ulcerated lesion, it's not necessary. But
Okay.
when we have a doubt with these,
Mm-hmm.
if you have a doubt to whether to confirm whether it's an eczema or an
Yeah.
early necrosis, we can, and histopathology will help if
Okay.
feasible.
Anybody else want to say something? Yes. Anybody else wants to?
Dr. Patwardhan here, sir.
Yes, madam.
I just wanted to ask the patient with fluid overload,
Mm-hmm.
uh, how much fluid was he receiving every day to
The
create such an
GP's
overload?
GP, he was calling immediately post CT scan. So 8 days she got around 1 liter every day. So total 8 days, 8 liters plus whatever she may be consuming at her home. So it was a very significant fluid overload. So we asked whether it was a big saline or a small saline. So she specifically told us it was a big saline plus a small saline. Possibly it may be some antibiotic, or it may be some multivitamin or something. So that was her answer.
Okay, but then maybe, as you said, that post-COVID, anyway, they have a tendency to sort of overload.
But this was
That
not
might
seen
be
in all patients. This was seen in very few patients who had some abnormal, like they were ischemic heart disease, or they had some CKD, uh,
okay.
cor pulmonale, like that. So only few patients, not but majority did not have. Only these two patients had I have seen with a volume overload, and this was an iatrogenic volume overload. This was something very funny, and that's
Not
the reason.
mental habit, that's
And
not
this
really
GP was getting exposed every day, calling to his clinic a COVID positive patient, and then we can understand why these GPs get more COVID. And this was an eye opener for all of us. And this is a means iconic case which should be published, or should be told to most of the GPs what should not be done.
not be done. Thank you.
Any more? There is one more. Mm, there is a one question, Dr. Sudhamati. Most of them feel no post-COVID morbidity if their pre-COVID compliance is stable and early intervention. That's correct, I feel. So I think in our cohort of around 217 patients, this post-COVID morbidity was up to a month. But they were very mild symptoms, but they are also observed with other illnesses also, other viral illnesses also. So even after flu, we get body ache, myalgias. So I think there is little bit of hype around post-COVID um, morbidity, and with fibrosis. This is actually, we feel that natural recovery does occur in more than 90% of the patient without any antifibrotic. This was the finding in our patient. So most of our patients, even they were prescribed, they did not take because of the side effects, or they took it only for a week or two and they just stopped it. But between the period of the first lung function and the second lung function, none of the patient took antifibrotic medicines, and there was a significant improvement in lung functions. And this is just 1 month observation. This is not something over a period of 6 months. So if, and this is not a cross-sectional one-time study, which most of the Western articles have done. They have done a cross-sectional study of lung function, 1 point measurement. So with this, I would like to end the presentation. And if there are any more points, we can share on our group. Thank you and good night.